Good morning. Welcome to the Rotary Club of Hudson. My name is Marilyn Orr, President of the club, and we are thrilled to have you join us today. This meeting broadcast is available on HCTV, as well as our Rotary of Hudson YouTube channel and Facebook. Our club meets weekly using this digital platform, Zoom. When we meet in person, it's at Laurel Lake Retirement Community for breakfast. We hope to get back to that soon. We meet most Wednesday mornings from 7:15 to 8:30 a.m. So come out to join us for a meeting. We would love to have you as a guest. To learn more about Rotary, our club, and the impact we are having on our local community and the world, please visit our website, rotaryhudson.org. So enjoy this meeting today and help us share the message that Rotary opens doors of opportunity.
Good morning, everyone.
Good. Yep.
Are you ready, James?
We are ready.
Okay. Good morning and welcome to the Rotary Club of Hudson. It's good to see everybody this morning. A little cool, a little too cool to run out early and play golf. So I'll stay for the meeting. How about that? Our invocation this morning is by Rich Warfield. Rich?
Make sure you unmute, Rich. There we go.
Can you hear me now?
Yes?
Good morning, everybody. And I see Andy Morse made it up. Good for you, Andy. Let us bow our heads and we'll say a prayer here to start our club meeting. Lord God, thank you for this time together. Thank you for the apparatus of Zoom and allowing us to see each other's smiley face. And Lord, may we go about our day with you in our heart and our mind. And Lord God, I pray for our politicians that they act like big boys and behave going forward, both on the national level and also on the local level, Lord. All we can do is pray for them, and we appreciate the time they give to us. In your great and powerful name we pray. Amen.
Amen. Thank you, Rich. And to lead us in the pledge and the four-way test, Jim Young.
Good morning, Rotarians. Join me in the pledge. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation under God, indivisible, with liberty and justice for all. And now the four-way test of the things we think, say, and do. First, is it the truth? Second, is it fair to all concerned? Third, will it build goodwill and better friendship? And fourth, will it be beneficial to all concerned?
Thank you, Jim. And now our president, Marilyn Orr.
Good morning, Rotarians. It's starting to feel like fall outside, isn't it? I want to take us a few moments this morning to introduce our newest member, Chris Foster. Chris, welcome to the Rotary Club of Hudson. John Adams and Rich Warfield will be mentoring Chris as he learns more about our Rotary Club and the events that we're so well known for, and also for the fellowship we share. Chris will be scheduling a time for you to introduce yourself to the club in the next few weeks, but it's great to have you joining as a member. We're going to jump right into today's speaker, and I'd like to have John Adams please unmute and introduce today's speaker. It's a very timely topic.
Thank you, Marilyn. Good morning, Rotarians. It's indeed my pleasure to introduce respected psychiatrist Dr. Dustin Blakeslee, board-certified psychiatrist treating patients at Unity Health in Stowe, as well as the Blick Center in Akron. Dustin obtained her doctorate degree from Ohio University College of Osteopathic Medicine and completed her psychiatric training, psychiatry residency training at Northeast Ohio University's College of Medicine in Akron. Dr. Blakeslee lives in Cuyahoga Falls with her husband, Dr. Pat Blakeslee, and their daughter, Caitlin. With all that's going on, we thought it would be great to have this topic of depression and mental health addressed by a speaker. And I appreciate Dr. Blakeslee reaching out, or I appreciate Dr. Blakeslee accepting the invitation to address this topic. So with that, her title is Depression. It's Not a Weakness. So with that, allow me to introduce you to Dr. Dustin Blakeslee.
Good morning, everybody. Connections seem to be good this morning.
Yes.
Great, John, thank you for that introduction, and thank all of you for your interest in learning about the mental health disorder of depression this morning. I'm going to take a moment and get my screen up and shared. Okay, everybody can see that okay?
Yep.
Great. So let's start with the definition of a mental illness. So a mental illness is a mental, behavioral, or emotional disorder that can affect an individual. And it can vary in impact from really no impact in one's functional impairment to severe impact in functional impairment. The graph on the right side of your screen is from the most recent study completed by SAMHSA, which is the Substance Abuse and Mental Health Services Administration, done in 2017, and it showed at that time of the survey, the prevalence of any mental illness in US adults was about 20%, working out to be 1 out of every 5 US adults to have an identified mental illness for 46 million adults. At the time of the survey, there was about 250 million adults in the United States at that time. You can note from the survey that there's a higher prevalence in women, there's a higher prevalence in young adults, and there's a higher prevalence in adults identifying with 2 or more races. If you look at serious mental illness, that's an individual who has a mental, behavioral, or emotional disorder that's causing significant impact in their ability to fulfill major life activities. So maintaining a job, securing housing, having fulfilling relationships. That was identified in 11 million adults at the time of that study for about 4% of the population. Again, a higher prevalence in women and young adults and individuals identifying with 2 or more races. And then if we use that study to look closer at depression, which is definitely one of the most common diagnosed mental disorders, known to affect about 15% of all individuals at some point in their lifetime. At the time of the study, 17 million adults identified with having at least 1 episode of clinical depression in the past year. Again, higher prevalence in women, young adults, and adults identifying with 2 or more races. Risk factors for depression, definitely a very complex illness with many contributing factors. A clear link when individuals have a family history of depression, which suggests there is this genetic component to this disorder. Traumatic life events can be risk factors. So abuse, neglect, bullying, online shaming, assault, major life changes. So job loss, bankruptcy, relationship losses, divorce. Those can definitely be setups for the development of clinical depression. Medical illnesses, specifically ones that are disabling. So multiple sclerosis, Parkinson's, Lou Gehrig's disease, things that have chronic pain syndromes attached with them, or cancer diagnoses. And then finally, medications. There's a handful of medications that are known to be associated with depression, such as Accutane, which is used in a lot of teenagers for management of acne. Signs and symptoms of depression. So this slide shows kind of diagnostic criteria for depression. To make a diagnosis of major depression, also called kind of clinical depression, one has to have at least 5 of these symptoms almost every day for at least 2 weeks. One of those symptoms need to include either sad mood or loss of pleasure or interest, which is also called anhedonia. You can see that the combination really results in a presentation of depression that would not be universal. So it can look different from person to person, but still be considered an episode of clinical depression. So for example, one can have a really robust appetite and put on a lot of weight during their episode of depression, where another person may stop eating and lose a significant amount of weight in a short period of time. Some people will sleep all day. Some people report to me that they can't sleep at all. Psychomotor activity change means someone might be really lethargic, or somebody else might be really restless and able to calm down. Low energy, beliefs of worthlessness or guilt, concentration difficulties, inability to make decisions, and then thoughts of death or suicidal ideation. So again, the combination can result in depression looking different from person to person. Treatment of depression, ideally, everybody would seek out and obtain adequate treatment for their depression. Unfortunately, that does not happen for a variety of reasons. That study from 2017 showed 35% of people did not receive any treatment for their depressive episode. Treatment needs to start with evaluation by a healthcare provider. If one does not have an established psychiatrist, psychologist, clinical counselor, they need to start with their primary care physician. And the first part of that decision is going to be determining a level of care. Does this individual need to be in an inpatient setting? Can they be treated in an intensive outpatient program that's affiliated with lots of hospitals in the area? Or can we strictly do outpatient treatment with a primary care doctor and a counselor, or do we need to get a psychiatrist involved? Individuals that warrant inpatient hospitalization are those that are having unmanageable suicidal thoughts and wishes for death, or those individuals who have such functional impairment because of their depression, they cannot be adequately supported at home. So they're not taking showers, they're not eating, they're not drinking. So those are the people that end up meeting criteria for inpatient hospitalization. Treatment can include counseling and or medications. Most studies have shown that people do best when they receive the combination of counseling with medications. Counseling can be provided by a licensed social worker, a licensed clinical counselor, a psychologist. What's most important is the individual finds one of those individuals that they really can trust and be honest with as part of their treatment. Medications, dozens of medications out there for depression, with almost all of them based on the theory that depression is related to a chemical imbalance, specifically a deficiency in specific neurotransmitters. So all of these medications work to increase those neurotransmitters in the system. The frustrating thing with these medications is they're not antibiotics, so they do not make things better in 7 to 10 days. We're really probably looking at 4 to 6 weeks, and that requires really consistent dosing of that medication, and that dose might need to be adjusted in 4 to 6 weeks. And then in cases where we have a treatment-resistant depression, that an individual is not responding to antidepressant trials, or in cases where there's really disabling depression, one could consider pursuing brain stimulation treatments. So those are things like shock therapy or ECT, which has a remission rate of about 85%, or transmagnetic stimulation or TMS, which uses magnets to kind of change brain chemistry. That doesn't have as much efficiency as ECT, but both of those are really important treatments in certain scenarios. So I wanted to take a moment to talk about the disparity in responses that I know are out there, unfortunately. If you look at individuals who have experienced a heart attack, they're often going to get a hospital visit, they're going to get a get well card or gift, they're going to get uplifting comments, and maybe even supportive actions. Let me take out your trash, let me bring you a meal. Depression often looks differently to those individuals. They're often met with kind of silence because people don't know what to say. Avoidance, people stay away because they don't want to make things worse, or again, they don't know what to say, or unhelpful responses. So those unhelpful responses, snap out of it, get over it, cheer up, think positive, things could be worse, no one said life would be easy, everyone goes through dark times and you don't look depressed. I have to believe those people that make those comments had good intention. But I think they're missing the fact that they're ultimately very dismissive comments and invalidating. So comments that would be more helpful include, you're not a burden, you have nothing to be ashamed of, your inner critic is wrong. So a lot of people with depression have really kind of negative self-talk, and it gets to the point that they believe those things that they're hearing. So pointing out to a person that your inner critic is not accurate. You do have positive traits and talents. I'm here for you. How can I help you? And I love you. So I think that's just, I think, important to pay attention to the words that we're using to be supportive to individuals. So suicidal thinking and behaviors, which is unfortunately common in individuals that are experiencing it in an episode of clinical depression. And these are very complex situations, and they don't have a single cause, but they should never be considered a normal response to stress, depression, or anxiety. So a study completed again by SAMHSA in 2018 found that over the previous year, 10 million adults had thoughts of committing suicide, which works out to be about 4% of the US population, with 1.3 or 0.6% going on to attempt. When they looked at the responses, the prevalence was equal in men and women as far as who were having the thoughts and who were making attempts. And who were making attempts. So if we look at suicide rates in the United States, and this study was from 2018 data by the CDC, the average rate across the country is 14 out of 100,000. So out of 100,000 individuals, 14 complete suicide every year. You can see that Ohio falls a little bit below that average at 11.4 to 12.5, where kind of the Midwest and Alaska hit our highest rates of up to 22 out of 100 people every year complete suicide. Of note, the suicide rate in 1999 was 10 out of 100,000. So we've seen an increase by over 30% in that period of time. Annually, there's 800,000 suicides a year, which works out to 1 every 40 seconds, leading it to be the 20th leading cause of death worldwide. Suicide rates by age, so completion rates, as you can see, men account for 75% of completions. And their prevalence rate hits 20 out of 100,000 in young adulthood, and then steadily increases as one gets older. So Caucasian elderly men definitely carry the highest rate of suicide completion. And this graph from the CDC in 2018 shows the leading causes of death in the United States. And I would surmise that from what we hear in the media, no one would ever know that suicide is in the top 10 leading causes of death and has 2.5 times as many homicides in our country. You can see that suicide is the second leading cause of death in individuals under the age of 35, and in the top 5 leading causes of death in individuals under the age of 55. And then the final data on this looks at actual completion methods, and over 50% of completions overall are by firearm, with that being the chosen method by men who go on to complete suicide. So risk factors for suicide. By far, psychiatric conditions probably carry some of the highest risk factors for suicide, with mood disorders, specifically depressive mood disorders, carrying the highest lifetime prevalence of suicide attempts as well as completions within the psychiatric conditions. But other diagnoses like post-traumatic stress disorder, bipolar disorder, schizophrenia also have increased risk. History of a suicide attempt is another significant risk factor for suicide. Family history of completed suicide, an active substance abuse problem. So data shows about 25% of completed suicides occurred in individuals that have an active alcohol misuse problem. Immediate access to a firearm, an abusive relationship, medical conditions, those same medical conditions we talked about as risk factors for depression come into play here. And then media coverage. This is known as the suicide contagion or the Werther effect, that when the media runs stories about completed suicides, and specifically with celebrities, there's an increased risk of suicide in the subsequent weeks. So the media really has to be careful of how they put that information out there. So suicidal thinking. I have no purpose in life. I don't feel like I'm living. I want to stop suffering. I will never be able to get over this. This is, I lost my job. I lost my relationship. I'm in bankruptcy. I have, some type of health condition. I have no hope for my future. I am burdening others. Others will be better off without me. No one will miss me. I really think that the suicidal thinking is a symptom of depression, right? So depression really distorts your thinking into believing these things. So when there's the intercross of I'm alone, I'm a burden, things will never get better, that's when the desire for suicide sometimes becomes unsurmountable for individuals. And then there's barriers for people wanting to disclose their suicidal thinking. They're afraid to go to the hospital. They're ashamed of their struggle. They fear that they're going to be called attention seeking. They don't want to be criticized, judged, misunderstood. They don't want to burden others. They feel unworthy of the support. They lack a safe space to talk about the suffering, or they don't want to be stopped. So suicide warning signs, and let me be clear, there's not always warning signs, but these would be warning signs if you're able to see these in individuals around you. People talking about wanting to die, ways to kill themselves. Others would be better off without them. I'm tired of burning people. I don't see a way out. There's no hope for my future. I'm trapped. I want the suffering to stop. Life being pointless, unbearable pain. You see them socially isolating. You see an increase in the use of alcohol or drugs. You see reckless behaviors that they've never had before, you know, driving at high rates of speed, giving away possessions, saying goodbye, putting affairs in order. So what do? I mean, the first step needs to be ensuring their safety. And in some situations, that's going to involve, I need to call the police. We need to get you to the hospital. We need to call EMS. Once safety is assured, we need to ask and kind of listen empathically and not force the conversation. Don't problem solve, don't judge, but listen. Remind them I'm here, you're not a burden, I love you, we're going to figure this out. Empower them, encourage professional care, and then check on them. Follow up to make sure that they're doing okay, that things are moving in the right direction. So self-care practices in the midst of all of this to ensure all of our overall wellness. I think all of us need to work to address emotional pain. There's going to be feelings of grief, anger, rejection, failure. And while we often cannot control the causes, we need to work to address that emotional pain before it turns into a clinical depression. And that might require counseling with your pastor, with your counselor, with your primary care doctor. We need to work to maintain our own self-esteem. So we have to have self-compassion to protect against feelings of failure or feelings of rejection, and not to develop a false sense of doubt of oneself. Avoid kind of repetitive negative thoughts. So interrupt that overthinking process that happens about distressing and negative events. You know, thought stop and try to redirect to some type of positive thinking or a different type of activity to get away from that. Manage one's stress. So look for solutions to controllable stressors, accept that sometimes there's not going to be, but continue to find ways to kind of manage those stressors, because ultimately chronic stress is going to affect one's physical health as well as their mental health. Make time for yourself. This is to reflect and de-stress. It shouldn't be considered as selfish. It should be considered as self-care. Making time for family and friends to not result in disconnecting or contributing to more loneliness. And then have good self-care practices. So eat, sleep, take your medications, exercise, manage your medical and physical problems. Help others. Volunteering can often boost our own kind of self-esteem and self-worth. And then ask for help if you need it. So resources I wanted to put out there moving forward. The first two are both suicide prevention lifelines that are answered 24 hours a day by clinical professionals. The National Alliance for Mental Illness, or NAMI, is a grassroots national organization working to support and educate individuals and their family members who are affected by mental illness. We have a very active local Summit County chapter that is always welcoming of support, financial or donations or just involvement to support their cause. I did put the link down there for an upcoming NAMI walk that I'm participating in, if that's something that will interest you to join me or to donate. Again, it's kind of virtual on our own trails, but we'll still do that. And the last two are the Depression Project and Project Semicolon, that I think have really good information for identified patients as well as family members about symptoms and support systems. So, questions this morning for me that I'd be happy to answer if there are any?
Dustin, that was great.
Thank you.
just looking over the comments here. Any questions from the group for Dustin?
I have one.
Yep.
Yes, Doctor, thank you so much for your time this morning. I'm curious about what you see as societal contributors to this problem. I mean, Western world is healthier, wealthier than it's ever been, and yet there's this sort of surprising rise in depression and suicidal ideation and completion. It seems like those shouldn't go together, but they certainly are. How do you reconcile these?
I think the correlation of the pressures that come with the developments in our society, right? Like, I think it's harder than ever to maintain boundaries between work and family time. I think the connections with social media, I think that contributes to the constant influx and barrage of what we hear and see from other people. So I think it's really complicated, but I don't necessarily think the development has developed in a way to keep us all well. I think it just ends up adding more stressors,
Could I just follow up then? Like, what would be some ways in which you would suggest that people kind of combat the societal changes? How would we go about, turning the clock back, as it were, a little bit?
I mean, I have a lot of conversations with my patients about setting up kind of self-care boundaries without guilt. And that's kind of the hard one, of not feeling guilty about turning down invitations or not accepting everything that comes at them, and making sure that they kind of have boundaries between work life and professional life, and just taking care of oneself. I had a lot of conversations throughout the pandemic early on about, I think you need to turn the news off. I think you pick kind of one update for the day, and the rest of the day, we don't need to listen to this all day. And just being able to pull ourselves away from some of that stuff and doing kind of healthier practices. But while at the same time, I think, how do we get involved to kind of make some positive changes in our society? What do you feel passionate about getting involved with to try to make some positive changes out there?
Dustin, that's such a great input about one news input a day. I certainly know in my world of finance, the news cycle 24/7, and with the fear that they are constantly pumping into people, makes my work as a financial advisor, the math part of it is easy in my work. It's the managing people's emotions that bring it challenge sometimes.
Dustin?
Yes.
You use the terminology completion. Is that when someone starts and attempts to take their life? And if that's truly the case, or the definition, what is the percentage of people that actually fall through for saying, I'm going to do this?
Completion means someone took self-directed actions with the intent to take their own life. And were then ultimately successful in ending their own life through that method. So the rate in our country is 14 out of 100,000 complete every year. To that number of about 50,000 a year are ending their own life intentionally by a self-directed action. That one slide showed that about 4% of people have thoughts, and less than about 1% actually attempt.
Thank you.
Yeah, Dustin, I have a question. So in my family, my children have faced depression, and we went out to get resources and found out that there is a really, really severe shortage of psychiatrists and psychologists for children.
Oh, absolutely.
Anyone you talk to has literally their practice is full, more than full. Is there a reason for that? Is it tough to attract people to this area, or Or is
I
there some
think- I
way
think
that
it-
that could be encouraged, that we could have more resources available?
Yeah, I think it's multifactorial, right? Like, I think you have to have individuals who are interested in serving in this type of work and being trained in a way that they can serve in this type of work, but not be destroyed by it. You know, I had a lot of training in my residency of how to take care of myself when I was sitting and hearing these other stories and trying to help individuals through that. As far as a psychiatrist, as you guys probably know, a psychiatrist goes through medical school, and then you do 4 years of psychiatric residency training. And there's only so many spots in the country, right? And those spots are determined by how much funding there is to fund those spots. So, you know, the program locally through Akron, Jarrell, and Summa train 4 to 5 individuals a year. So they're only graduating 4 to 5. And as you can imagine, it's sometimes very difficult to attract them to stay in Akron when they finish. So I think that kind of limits the training on that. And I think there's a lot more spots for psychologists and clinical counselors and those types of individuals. But again, it comes down to how do you attract those people to that position because of the work. I think that's kind of the one factor that's probably the most significant within that. I don't know how you change it. I mean, you can't force someone to do you know, something they're not interested in doing. The reimbursement for work as a psychiatrist is nowhere near that of a dermatologist or an orthopedic surgeon. So I think that gets complicated. I think it's really unfortunate when individuals want to get help that they often can't get help as quickly as they want to because the resources aren't immediately there. One of the frustrations I continue to run into is that some people have insurance coverage through their employer that doesn't cover mental health treatment, which seems absolutely ridiculous to me, that insurance companies and their employers are able to offer insurance plans that do not provide them any coverage to treat mental health issues. When we talk about why is it any different than any other type of medical condition, but they still see it that way and refuse to pay for treatment of things like depression or alcoholism.
Yeah.
Movements trying to address that to make sure that mental health and substance abuse conditions are viewed as any other medical condition out there.
I have a question about isolation. There are, I think at the present time, there seem to be more people who are isolated from their support systems.
Mm-hmm.
And I live at Laurel Lake, which is a full care facility. And we have many residents in independent living as well as in the higher levels of care who have been totally isolated from their families for 6 months or more because they don't have the capacity, or their families are away. They don't have the capacity to get in their car and drive off campus. And we really don't have internal treatment capacity to deal with depression. And I know that there are many friends and neighbors, and of course this is one of the populations that has, you know, we've been asked, well, people just give up. And that's a form of suicide when you get to be in an elder population. So I don't know if you're aware of ways to get that kind of expertise to serve. I think we have 6 or 7 senior living congregate facilities in Hudson. And I think that, you know, that we potentially have a huge social issue in this community. I don't know what solutions there are to having that capacity when it's short everywhere.
Right. I would hope that there's more access to kind of telehealth visits. I know I transitioned to almost exclusively doing, you know, Zoom-based televisit sessions throughout a good bit of the pandemic. So I mean, there's resources out there to connect with mental health providers through a platform like this. And I know there would be challenges of making sure that that technology is there and somebody can support that. So I think, you know, while I do believe a lot of the restrictions were necessary to keep us safe through all of that, there were definitely negative consequences to the isolation that came with it. So it's kind of this two-edged kind of sword of, it feels like we're keeping you safe, but it really doesn't feel that way when I'm isolated from anybody else.
Yeah.
So I think at the time being, you know, if facilities can somehow, you know, safely set up kind of support groups within the community and bring in people that are trained to help with coping skills and other types of distraction techniques, I mean, I think that would be ideal. But yeah, I mean, there's definitely challenges in normal circumstances to get to services. And then add this one on top of it, it's really difficult. And I think everybody's being asked to kind of extend the scope of their work, you know, so I would hope that people at your facilities and others, you know, are spending a little bit more time with the individuals that are isolated from their families otherwise.
I think there are efforts to do that, but people are really good at hiding depression.
Oh yeah.
Yeah.
Right. So I think that goes back to how do we keep working on removing the stigma of being able to talk about, I'm not well, I do feel depressed, I need help, and seeing that it's not a weakness, and it is a treatable condition just like diabetes and high blood pressure.
Dustin, I have a question about psychiatric diagnosis. I was involved with a family member that had depression, and there was depression in the family, and yet the psychiatrist assured this person that they were non-suicidal. Can you make that diagnosis? I mean, it gave great comfort because other suicides had happened in the family. But I always wondered whether that was legitimate.
Yeah, I don't know how you would, you know, when I sit with an individual and identify them to have a clinical depression based on their presentation, and screening whether or not they have, you know, starting at the far end of the spectrum, you know, have things gotten to the point that sometimes you wish you weren't here anymore. And somebody who endorses that would be considered of having passive suicidal ideation, right? And then I have to follow up with questions of, has it progressed to the point that you've actually wished to be dead, thought about doing something to end your own life? Have you given any real planning to that, and really work down those questions to see how developed those suicidal thoughts are? Even in those individuals who deny to me that they have suicidal ideation, I still need to be able to see other risk factors, right? Is there a recent end to the relationship? Do they have an access to a gun? Do they have no support system? Have they attempted suicide before? So I can't believe them at face value when I see other risk factors. And sometimes I'm just that frank with patients. I have to tell you, I'm really concerned. I hear you telling me you don't have any of those thoughts, but on paper, you have a handful of risk factors that I can't ignore and work through that. And that can change in a moment, right? So that patient could leave my office and convincingly deny suicidal ideation. I have no idea how quickly that could change. So maybe the individual at that time, at the time of the appointment, was thought to have low risk for suicide, but I wouldn't see that as protective or conclusive throughout the rest of that episode of clinical depression until there's remission, because it could change very quickly and unpredictably.
One more question, if you please. Have there been developments in the drugs to treat the chemical imbalance?
Kind of, sort of. So the majority of them still target to increase serotonin. That's the neurotransmitter that's thought to be deficient in individuals that struggle with depression. Some of them also increase other neurotransmitters like norepinephrine and dopamine, but those are typically the three antidepressants. They're the three neurotransmitters that these medications are working to increase to address the chemical imbalance part of depression. So even the first antidepressants out there did that. So they all might do it in a different way, but the end result is still the same. I think where we've gotten better is we've cleaned up these medications in a way that there's not as many side effects, there's not as many drug interactions. So I do think they're better in that way. To be fair, there's no antidepressant that's proven to be better than another. So in head-to-head studies, they all come out looking about the same. What I find that happens sometimes is that an individual sees their primary care doctor for depression, and the primary care doctor, well-being, grabs one of the newer antidepressant samples out of the drug closet. That's going to be crazy expensive down the road. So I still kind of practice in a way. Let's start with kind of one of the older-ish ones that's going to be affordable, that still has a good side effect profile and drug interactions, before we move to one of the newer, crazy expensive ones. Because again, those are not proven to be any better. So response to medications is probably around 50 to 60% with treatment with depression. And that's why counseling is such an important piece of that. And I always advocate that with my patients, but I really don't think medication is going to get us all there. And some of the triggers for your depression, my medication is not going to fix. So there needs to be a counseling part of your treatment to address kind of these environmental situational stressors and to improve your coping skills with those.
Thank you.
Mm-hmm.
Dustin, Marilyn Orr has a question.
Okay.
I actually have two.
Okay.
The first is a concern over, I guess you could say, the age at which depression is becoming identified. I see it being younger and younger and younger. At one point in my life, I felt it was really high school that we might be seeing, manifestations coming forward from people in your family or people that you knew or children of employees. And I'm now starting to feel that it's happening much, much earlier in middle school and maybe elementary school. And I'd like to know why you think that might be. And then I have a second question once you finish.
Sure. I think some of it might be we're better at identifying it to some degree. I think maybe we're more aware and we identify it better. I think that's the same when you look at like autism. Like I don't necessarily think rates have gone up. I just think we got better at identifying it and making the diagnosis. Again, I have to believe it comes back to just the stressors that age group has compared to what they had 20 years ago. I mean, I look at my own daughter as a freshman and sophomore in high school, and I didn't have that. I didn't have the constant exposure to media and Instagram and to have all that influence and opinions kind of constantly coming at you. And then, in the potential for kind of the online shaming and the bullying and comparing myself to this person or that person. So I think studies have shown just the impact of kind of social media is there, and then just the pressures of society that I think feel different as adults, but also feel different as kids.
The second question deals with safety forces. Our police officers, our guidance counselors in our schools, and the training that they receive and how effective that has been in identifying and then also in working through issues. Could you address that a little bit?
Maybe a little bit. I mean, I know that our local police forces offer training for crisis intervention officers. So officers identifying an interest in additional training for mental health disorders, substance abuse issues, and how to interact with those individuals go through a training program run by one of the local mental health agencies with the involvement of psychiatrists and counselors to provide education that would ultimately, hopefully, increase their ability to identify those individuals that are having a mental health or substance abuse crisis, and then know how to intervene in a way that's not going to escalate the situation. So if you are ever in a situation that you need to call, authorities, learning to ask for, can I have an officer that has crisis intervention training? Hopefully it becomes mandatory because I think it's just so important that we learn not to escalate situations that are already there. I don't know specifically what they do within schools. I can't speak to that, but I would really hope that those officers have additional training as well before they're put in such positions.
So let me ask this question. So I had a brother-in-law who committed suicide many years ago, and sadly, one of the things he was contemplating in his note was taking his own children with him.
Mhm.
And he ultimately decided not to do so. Could you begin
Oof.
to share anything about the thinking of the individual that, in addition to harm to themselves, would harm innocent
Right.
children?
Yeah, I mean, definitely tragic and rare when it gets to that point. And I think that shows you just how distorted one's thinking becomes, that they see that there's no option for themselves, but they also see that there would be no option otherwise for their children, that it's hopeless for all of them. I will share, I've had 2 suicides in my practice to date. And the saying goes that as a psychiatrist, if you haven't had one, you eventually will, which is tragic. And it was a woman who was 36 weeks pregnant and killed herself, and the baby ended up dying with really no identified risk factors for suicide. I mean, it was beyond, I can't tell you how much that affected me, and how I even begin to understand how she got to that point to think that there was no other option. So I think it just shows you just how distorted one's thinking gets at that point. Some people with really severe depression can develop psychotic symptoms, so which really becomes kind of delusional type of thinking. And sometimes you wonder if that's what happened in some of these scenarios. Did their thinking become so distorted that it became psychotic in a delusional way, that maybe they were having paranoid thoughts, and that's what contributed to kind of the suicidal and homicidal actions at the end of it.
See that Dave Basil has a question. Dave, you still with us?
Yes. Thanks, John.
Sure.
Doctor, just looking for your perspective, there have been a lot of reports about the reduction, the absence of inpatient care options and the impact socially of that. And I'm just interested in your perspective on that issue.
The increase or decrease in the context of the pandemic, right? I just don't understand what the question is.
Well, I'm sorry, no, inpatient care facilities, psychiatric facilities, the beds being reduced, number of beds being reduced,
Yeah.
The absence of those facilities, and then the impact. A lot of folks that are homeless really have mental health issues. And in the past, the reports are that they typically would have been in inpatient care facilities, and that those are no longer available.
Yeah, I mean, fortunately, I mean, our beds in the local area have been stable for the last many years. So, I mean, we have over 100 psychiatric beds in Akron, between Akron General and Suma, and that number has stayed pretty much stable. But I mean, you're correct. I mean, the unit down in Altman closed earlier this year. And unfortunately, medicine is more of a business than I ever realized. And it often comes down to, it's not bringing in money for the hospital, so let's find something else to do with the space. I also think there's been a change in how sick you need to be in the hospital. And that's the same with pneumonia. You know, you have to be so sick with pneumonia to get admitted, and you have to be so sick with depression to get admitted now. So there's more of a push to do outpatient programming. Again, we're very fortunate in Summit County to have lots of intensive outpatient treatment programs for adults as well as adolescents, that an individual goes to 5, 6, 7 hours a day and learns intensive coping skills in addition to seeing psychiatrists, but then can be safely at home the other hours of the day. Does that begin to answer, or is there more to that? I'm sorry.
No, that's good. Thank you.
Okay.
James, you had a question.
Yeah, Dustin, again, thank you so much. This has been fantastic. So I'm on the school board, and for years we've been focused and worried about depression and stress for our students, and we've seen it grow and been trying to take actions within the schools to try and identify and treat that. Obviously with the onset of COVID and kids not being in school and that sort of thing, you sort of have two things. One is you just don't have that direct observation.
Right.
But the other one would be the effect of actually being at home and being isolated on depression and thoughts of suicide. Now, we've had some people tell us that, you know, those who are arguing for us to have the students in 5 days a week, that, you know, that this increase in depression and suicide would be a reason to do that, which obviously we are super concerned about, and that is one of the things we're considering. I'm just wondering, in terms of the actual experience that you've had or seen or read about, have you seen a spike in depression due to being home and being isolated and thoughts of suicide?
Yeah, I mean, there's CDC data that's starting to come in that definitively shows increased symptoms of depression, suicidal thinking, and substance use disorders, right? So alcohol misuse is a big one. So early data is definitely trending in that direction. It's interesting that the majority of patients in my practice really struggled with the social isolation. I had a handful of patients that really have done better because it's taken away the pressures of the outside world and some of the drama that came with that and gave them a reason to kind of pull back from all of that stuff. Again, a smaller percentage. And I think we've seen that in some kids as well, that most, I think, have struggled with the social isolation. For better or worse, they're all pretty good with social media and have found a way to stay in contact with each other. I think that's probably one good thing about social media that's out there. But yeah, early data is definitely showing it's kind of trending in a way that this has had a negative impact on mood and an increase in suicidal thinking.
I'm sorry, is that across all ages or specifically for children?
Yeah, it was across all ages. It definitely looks to be highest in individuals under the age of 25, which are, again, those individuals that are used to being around people, used to being really social. So it does look to be higher in that younger age group than not.
Thank you. Yeah.
Dr. Blakeslee, one more question.
Yeah.
I have I know that there are tiers of care. There are psychiatric nurses that are providing talk therapy and care. There are psychologists, there are psychiatrists. How do people connect, and where do they enter, and what is the best fit? How is that determined?
Yeah, I think that's a really good question, and hopefully individuals have a primary care doctor to kind of guide that process. People rarely start with me, right? You rarely have an episode of depression and start with a psychiatrist. So you should start with your primary care doctor. Your primary care doctor could initiate medication therapy if that was thought to be warranted, and then get you connected to a clinical counselor, social worker, psychologist that can do counseling. So I think that is the entry point. That needs to be the first step. And then depending on response to treatment, we can decide, okay, maybe we need to escalate care and get a psychiatrist involved at this point. But I think that first conversation is with your primary care provider and deciding, okay, we can do this outpatient. Let's start this medication. I'm going to refer you to do counseling here, and then kind of close follow-up at that point until we see kind of a remission of symptoms. Most psychiatric nurse practitioners are going to function more like a psychiatrist and focus more on kind of medication management. So again, involved with a nurse practitioner, probably still need to have a counselor, because at the end of the day, psychologists get way more counseling education than we do as psychiatrists or trained nurse practitioners.
One more question, back to insurance. Medicaid covers a lot of people, young families in the state of Ohio. Also, I know that there is a two-term subject called case management that insurance companies use, and prior authorizations and fees in and out of network. Can you address some of that difficulties that people are encountering with that?
I mean, it's a light question to wrap up, Dustin. Right?
Yeah, I mean it's just a mess. I mean, it truly is just a mess. I mean, you said like the word prior authorization, and that makes me like bang my head on the table of the phone calls I have to make and be on the line for 20 minutes for 2 nonsense questions to get things approved. So I think that's such a higher level issue of how do we begin to resolve that. The thing I never realized is, you know, I see patient A with this insurance, I see patient B with a different insurance, I do the exact same thing, I get paid differently, and often substantially differently. Like, what is that about? So I think it's just such a mess. And how do we begin to fix that? And I just want to like take care of patients and do the right things. And then when you see all the business behind it, it just makes it really difficult to do that sometimes.
It's counterproductive.
Yeah. Yeah. I mean, I learned yesterday that my group has decided to end their contracts with Anthem and Aetna Medicaid over a disagreement in how much they're willing to pay us for care. And so now I have to approach these patients about, I can no longer treat you because I no longer have a contract with your insurance provider. Like, that just doesn't seem right.
Right. And it works the other way too. Insurance companies often will drop physicians.
No, right. Like, it's just
no reason at all. And the patients are kind of stuck out in limbo as well.
Well, and you know, these treatment relationships are very special and can be very fragile. And it's just not something you can easily start over and do, you know?
The model is broken.
It is.
Right. It is definitely broken.
Well, let me wrap here a bit by just saying, Dustin, you've been fantastic. The responses that I'm seeing in our chat on the side, everyone is commenting how phenomenal you are and how great this session is. So, you know, from Rotary, we really, really thank you for setting time aside from your family and your profession to share with us your expertise on this incredibly relevant and important topic. Marilyn, is there anything you want to add to wrap this up?
There are a few comments I'm going to make. We are, as Dr. Blakeslee had indicated earlier, we are 6 months into this, and we're by no means assured that we are halfway even through it.
Right.
But, you know, it's important that we understand it, and it's only by seeking out speakers such as this that we can better understand it. She was very kind in listing some of the resources, and I'm going to include those in our weekly bulletin so that you can use those as, once they're identified, as a place to go for reliable resource information. You can't Google this stuff. It's just not appropriate. So nonetheless, this has been an excellent first step. It's given us an overview of the process and the frustrations, and I'm hoping that things will get better.
Mm-hmm. Yeah, we have to be hopeful. I agree.
We do, and we have to be supportive of one another. And that's why it's so important that you have contacts. If you live alone, you need to talk to people every day.
Mm-hmm.
You need to take actions outside your home every day. And exercise is a wonderful way to participate and get some of that stuff going. Mm-hmm. But anyway, we're now going to talk about next week. Next week, we start the month of October, which is a focus on politics. And thanks to our member, Dave Basil, we're going to start next week with a candidates forum. State Representative Casey Weinstein and his challenger, Beth Bingham, a member of the Hudson City Council, will be squaring off. We are upholding our tradition of offering our candidates forum to the public, so invite your neighbors and friends, and we'll be looking for extra folks to attend our Zoom meeting. Again, thank you, David, for making these arrangements. Also, in 2 weeks, our club board will be meeting on Wednesday, October 14th, immediately following this Zoom session. It's anticipated that the meeting will begin at 8:35 and should conclude by 9:30, and all club members are invited to join us. And lastly, as I usually do, I'm going to close us out by talking about this day in history. In the year 1520, Suleiman the Magnificent was named the Sultan of the Ottoman Empire. He would rule for the next 46 years, and during that reign, it would become known as the peak of the Ottoman influence, with expansions via military campaigns. He reformed the Ottoman law system, and he fostered a very rich period of art and architecture. In 1791, Mozart's opera, The Magic Flute, premieres in Vienna, one of my favorites. And in 1846, in medicine, the anesthetic ether was used for the first time by a dentist, Dr. William Morton, who extracts a tooth. In 1953, Earl Warren was appointed the Chief Justice of the United States Supreme Court. And lastly, in 1962, James Meredith registers for classes at the University of Mississippi, the first person of color to do so. So we are concluding our meeting today. Thank you again to Dr. Dustin Blakeslee for one of the most interesting programs we've had this year. You set the bar very high. Set the bar very high.
You're very welcome.
Have a great day. We'll see you
Thank
next
you.